Hello, everybody. Thank you for coming to another session. Today we have Dr. Holt. I'm going to let her introduce herself. You guys can either unmute yourself and ask your questions, or you can enter them in the chat and we can just answer them periodically.
Let me just ask one question. You're all medical students, right?
They're all either pre-med or pre-health students.
Okay, sounds good. Well, thanks for coming. It's so exciting to see people who are interested in behavioral health. There's such a great need that you'll always be able to have a job in this field, that's for sure. My name's Alison Holt, and I'm a psychiatrist, and I did a fellowship in child and adolescent psychiatry, so I'm also a child and adolescent psychiatrist. And right now, I'm the physician chief of the mental health and addiction service line at Fairview, mHealth Fairview in the University of Minnesota. So did you want me to kind of just talk about my path to getting to deciding to do this?
Yeah, that'd be great.
Okay. And let me know if you want me to switch gears if I'm not talking about what you need. So I actually came into medicine late. I was 31 when I decided to go to medical school, and I decided to go, I knew that I wanted to be a psychiatrist when I went to medical school, although most people don't know that, and it's just people find out as they're on rotations. But for me, that's what I wanted to do, because I was really interested in the biological aspects of mental illness, even though I really believe in the therapy also, that's crucially important for treating mental health. But I was interested in the biological part because I like biology, and I had seen some people in my life who had gone to therapy and had depression, but once they started medication, it made a huge difference. And so I think that was one of the things that kind of led me to that instead of getting a PhD in psychology. So I went to medical school at Ohio State, and it's 2 years of book work and classes, and then after that it's 2 years of rounding on units. And so you see all the different types of medicine that you could potentially go into. And that's usually where people decide where they want to be. One of the things I was thinking of pediatrics, psychiatry, or OBGYN by that time. I was kind of interested in those things. And one of the ways that I made my decision was to think about what kind of articles do I like to read when I'm lying in bed? You know, when I don't have to be reading any articles, which ones do I want to read? And psychiatry was it. So I would say, you know, going for your passion is always best, and it's easier then too. It's more intuitive. It was just an easier move for me because I was interested in it and I understood it somewhat. So then after that, I went to residency at the University of Minnesota, and it's 4 years of general residency for general psychiatry. And then it's 2 years for child and adolescent psychiatry, although you can combine it so that it's just 5 years total. You start your child and adolescent in your last year because that's when you would be doing electives anyway. So I did that and graduated when I was 38. So there's no limit on how old you can be when you have a kid. Actually, I was like 40 when I graduated. So there's no limit on when you have to go to medical school. It's always fine to go later. And when I got to residency, I knew that I wanted to do private practice. And I was also interested in forensic work. I always had been interested in that. And so my last year of residency, I did a whole year of forensic psychiatry. So I evaluated patients who were not, you know, were pleading the case for not guilty by reason of insanity, or were not competent to stand trial. So it was those two questions that you have to answer in forensic psychiatry. That's part of it. And then I also worked in the jails and in the prison system. So that was also an interest of mine. And I did do that when I went into private practice. So mostly I saw patients, but sometimes I would also take cases for forensics. So that was interesting and really fun. I also did electroconvulsive therapy, and I chose to do that. I also did a year's worth of special work in that because it is one of the best treatments that we have for treatment-resistant depression and bipolar disorder. About 33% of people get better on one antidepressant. Another 33% get better when you add one or when you switch to something else. And then that's you're kind of left there. And so ECT is about 90% effective for all those people who have already been treatment resistant, who haven't responded to medication. So it's an underutilized treatment, and it's one of the best ones that we have. So I did that also. And then I worked in eating disorders. So it's not uncommon for psychiatrists to kind of move around and do different things. I think that's probably kind of common for all types of medical professionals, but in psychiatry, there's such a great need that you can always find a job. There is no problem with that. It was easy for me to start a private practice. I was filled up, within a few months, and that was just a matter of me having to keep up with new intakes. That was probably the rate limiting factor, or I could have been filled up much sooner. So then I decided to go in, I decided I wanted to help patients more on a macro level instead of sitting eyeball to eyeball and doing treatment, which I love that part, but I just wanted to make a bigger difference. And so I moved and became a medical director at Anthem, and we provided Medicaid for MCOs, managed care organizations. So I did that, and then I got this job at the University of Minnesota. So I am the chief psychiatrist for our service line, and we have 4 different hospitals that have psychiatric beds, and then we have a ton of outpatient programs, intensive outpatient programs, partial hospitalization, and then just regular psychiatry embedded in primary care. So there are a lot of different types of treatment that we have. mHealth Fairview, we are the largest provider of mental health care in the upper Midwest, actually, but for sure in Minnesota. So now my job is primarily administrative. I work with legislators. Later on today, I have a meeting with Peter Fisher, who is the representative, who is the chair of the Behavioral Health Committee, because legislatures they're deciding on bills, and they're working right now, which will end pretty soon. But so I work with legislators, and I work with the Department of Human Services and counties, and then just kind of overall manage growth for our system. And I think for psychiatry, we probably want less growth on inpatient because it's the most traumatic care, it's the most expensive care, and it's often not needed. We go to hospitals because there isn't enough of that intermediate care. So in psychiatry, we have a lot of intermediate care, but we have a lot of intermediate care types, but there's not enough available, like crisis beds, so that when somebody needs to go to the hospital, or they think they need to go to the hospital because they've had a huge fight with their spouse and they're feeling suicidal, that person doesn't necessarily need to go to the hospital. They often will need just a crisis bed who can manage that crisis, work through that until they are feeling a little bit better, and then send them home. Psychiatric units are pretty traumatic. You get everything taken away, no phone, no shoes with shoelaces. Everything has to be ligature proof so that nobody can hang themselves, essentially. And there's, it's a double locked door. You go through one door and then we call it a sally port. You're in there until the next door opens. So patients are feeling this and hearing this and seeing this. So it is a pretty traumatic experience. They can't call whenever they want to. Parents can't come and sleep with them like they would in other parts of the hospital. But, it is necessary for kids and adults who are absolutely psychotic and can't take care of themselves, or who are incredibly suicidal and have the means to do it or have done it, who have attempted. We don't say committed suicide anymore. We say completed suicide if somebody actually does complete the suicide and die, because the committed word is kind of like committing a crime. And so we're trying to take that stigma off of suicide. Not that we want people to do it, but it's not about committing a crime. It's about how much pain can somebody take. Maybe I'll take some questions. I have a lot to say, but I want to make sure I'm saying what you guys are interested in. So should we start with that a little bit?
Yes, I believe there's some in the chat.
Yeah, I saw them kind of popping up. Should I just look at them?
Yeah.
Okay. What did I do before medical school? I actually sold software with my father. We had a business where we sold medical software for billing, but then we were moving into charting. So we were at that early stage of computer software for medical and dental offices. So that's what I did. And then what are some subspecialties of psychiatry? So forensics is a subspecialty. You have to go to, or there is a fellowship available for it. You don't have to go to it, but it's better if you do, because there's a lot that goes into understanding, just because somebody's psychotic doesn't mean that they're not guilty by reason of insanity. You have to actually not be able to, at the time, differentiate true from false or right from wrong. And there are a lot of people who are psychotic who still know it is wrong for them to kill somebody. And so, so there's a lot of these nuances that you have to kind of understand. So that's one. Another subspecialty is child and adolescent. Another one is consult liaison. So it's basically the doctors who are very, very good at going on to medical services and understanding how medical comorbidities affect psychiatric issues and how the medications that they're using affect psychiatric issues. So that's consult liaison. What else?
Geriatrics, right?
I can't think of any. I know that there are more, but I can't think of them right now. So I'll kind of keep that in my mind and come back to that. For students who know they want to go into psychiatry before med school, do you have any advice for their journey? Well, this is what I say to all medical students or pre-med students. Don't, and maybe this is the wrong advice, but this worked for me. I did not worry about getting a degree in biology or some of the physical sciences. I knew that I wanted to, I was most interested in psychology, and so that's what I majored in, and it was fine. It didn't impede me, or it didn't cause me problems at all, and in fact, I think it was really helpful for my growth later on as a psychiatrist. So that's what I would say. And yeah, so if you know you want to go into psychiatry, I would say go for a psychology, because you don't get that as much in medical school. You don't get a lot of psychology. You get a lot of just medical treatment. You learn all of that in residency. What are some of the difficulties in psychiatry that you think someone should know before going into the field? That's a really good question. One thing that I didn't expect was that, and I don't know why I didn't expect this, but mental illness is a chronic illness. And so these are people that you see over a long time who get better, get worse, get better, get worse, or just kind of stay at a really low baseline of functionality. And so that, I wasn't prepared for that. I wasn't prepared for how ill the patients really were and how chronic that was. And hopefully that will change over time. Hopefully, as we have better treatments, we'll see more remissions. But right now, it's kind of like oncology. I mean, people are just really sick and they kind of stay sick. So that's one thing that I would say. Let's see if there's anything else. I think that's kind of the main thing. How was your experience going to medical school later in life at the age of 31? I thought it was great because by then I had a lot of, I had been working for 10 years or more. And so I was very disciplined, and that helped me with medical school because there's a lot of reading, there's a lot of work. And I never crammed, I never stayed up past 11 studying for a test because all of those years of working, I knew how to prepare and how to chunk out work. So that was good, I thought. It was also helpful because I had done a few different things in my life. And so I did know a little bit more what I wanted to do. It was weird always being around, always being the oldest, but it didn't bother me too much. I mean, it wasn't that weird. I would say that graduating when you're 40, however, from your residency is tougher because number one, you're more tired, but number two, you have a lot of loans. And so, it cut out like, 10 years for me paying back loans. And so that was tough. But hopefully that's going to change some. I work on a pediatric inpatient unit as a behavioral health specialist. Oh, thank you for doing that. That is such a tough job and we need you so much. So I'm grateful for that. During this time, I've had some very meaningful experience with patients. What is your experience you have had during your career that has made a lasting mark on you as an individual, encouraged you to stay in the field even when it gets difficult? I have followed patients over their lifetime, not into old age, but because I haven't been in psychiatry long enough, but I have patients that came to me as a 6-year-old, and then I saw them and worked with them for a while. They got better. And then I started working with them when they were 13 and going into middle school, and everything was difficult. And then, and maybe then I've seen them all the way through that. And now they're in college, and that is amazing to me. There was a patient that I had who was extremely psychotic, and he was in high school, and he got through college, and it was amazing. He has bipolar disorder, and which was triggered often by cannabis use. So we were kind of dealing with both of those things. And when he graduated, he sent me a thing of flowers, which was so sweet of him to do that. But really, just the fact that he graduated was unbelievably to me because he was so low functioning when he was ill. So that makes a big impact. I mean, I kind of get choked up even just talking about it. And then, the thing that I did for so long, which was see patients one-on-one, was really satisfying to me. It's very satisfying to me as someone who's interested in the mind, what people are thinking, what experiences they have, how did they interpret that traumatic experience that they had, and then the fact that they're telling me the most intimate details of their life. I felt very honored. I think that word's used too much. I don't usually use it much, but in this case, it's like the only word I can think of. It felt very special to me that they would share that with me. I had a patient who was, she had bipolar disorder and she was also psychotic, and but she started having these thoughts that she was going to kill her family. She didn't want to kill her family, but it was like it was OCD with repetitive thoughts. And when she finally told me that, we were working on it, I thought it was psychosis for a long time. And then she finally told me what was going on, and she was just sobbing. I mean, it felt horrible to her that she'd be thinking about killing her kids or her husband. And then she went into the hospital. She got into cognitive behavioral therapy specifically for OCD, and it fixed her. It was unbelievable. She still has bipolar disorder. She's still on a mood stabilizer, but it fixed that issue. Now it comes back sometimes, but still to see that kind of a turnaround was amazing to me. And then it also was very special to me that she shared that with me. And then the other thing that makes me want to stay in the field when it gets difficult is just that our patients in mental health are usually the most disadvantaged patients out of anybody. And there's just so much that they need that they don't have access to, that they can't give themselves, and there's so much trauma out there. And so I just have a place in my heart for that kind of, I don't know if it's the underdog thing or what it is, but that means a lot to me to work with people and try to change their trajectory in life. And that's one of the reasons I went into child and adolescent psychiatry, I will say, is that I wanted to get involved earlier to try to change someone's trajectory. Something personal about me, I left home when I was 15 and quit high school, actually. And so I got my GED before I did the other things. And it was a person in my life who changed my trajectory, because it was not good. Moving out when you're 15, there's just not a lot good going on there. And I feel like I want to do that for other people. So what do you think is the most difficult part of becoming a physician, and what personal qualities would be beneficial to overcoming these challenges? One of the difficult things to me is having to make decisions that are so important. What kind of med to start? Do I let this patient leave my office if they're suicidal? Those kind of decisions are heavy, and but so is neurosurgery. And you cut the wrong artery and that person dies. And so all parts of medicine are like that. It's a lot of pressure, and there's a lot of gravity to it. It's not you made the coffee wrong. So I think that's difficult. I think something that's important, personal quality, is leadership, because you will probably always be the leader of the team. I work with a team of people, but as a physician, we're always the leader, almost always. Really an ability to work hard. It's just really hard work, like to the point where, and I don't want to discourage you from going, but my son is going into medicine, and I tried to discourage him for a little while because it's just a really hard haul, and it's a lot of money, but I am so glad I did it. I don't know if I could ever do it again, but I am so glad that I did it. So I think that's important. You just have to love to work. Would you say doing research and working as a research assistant at a hospital would help when doing psychiatry? Maybe tell me a little bit more about this. Would help in terms of getting into psychiatry, or would help in terms of being a good psychiatrist? I'm not sure quite what that meant. If anybody wants to clarify. I mean, I think that doing research and working as a research assistant is absolutely something that's important, and it will help you get into medical school. I also think that it's important in having that kind of a mind of testing theories and testing hypotheses and being systematic in that way. So I think that research is helpful in that way. How do you work with patients whose families are very pessimistic about certain treatments and not very cooperative? That is a tough one. And so I think what I try to do is find our common goals. You know, what are our common goals? Is it, and then how do we get there? And I just take time. I mean, I've had parents who just won't start a medication, even though their child really needs it. And I just keep seeing them until I can kind of make a little bit of an inroad. And at some point, you know, you have to just stop because you don't have enough, there aren't enough psychiatrists. So we can't really be seeing a lot of people who aren't going to be taking medical types of treatment. And so, and then just education. People don't know about psych meds. Everybody thinks it changes your personality, it seems like. And everybody worries about the risk of suicide with the SSRIs or the antidepressants. And that's just such a low risk, but you just have to kind of educate people. What did you do in medical school besides schoolwork and studying for boards? Any research or volunteering? What are some of the things med students can do to broaden their experience? I think research is one of the things I did. I did biological psychology research. I was in a lab where we did that. I think that's helpful. I actually didn't work in a job when I was going to medical school. To me, I don't know that I could have done that. I just don't know that I would have had the capacity to do it well. So I just took out loans. I mean, it sucks, but that's just what I ended up doing. But I did a lot of it before I went to medical school. So I volunteered. I worked as a medical assistant for a while. Now you kind of have to be certified to do that. So I don't know if that's as easy to do, but I volunteered in the emergency department. My son is a scribe in the emergency department, so he's gotten a lot of good experience that way, and I think that that's helpful. How is malpractice insurance as a psychiatrist? Ours is lower than a lot of other specialties. OBGYN is extremely high because if you have a bad outcome when you're delivering a baby, you know, that has a huge impact, and they can sue you for a lot longer. But so our malpractice seems like it's around $5,000 a year, $6,000 a year, which is really low for psychiatrists. And there's a lot of literature that indicates that having good communication with patients and family really reduces your risk of being sued. And anybody can sue you, whether you did a good job or a bad job. Anybody can sue you for anything, but they typically don't, especially if you've had a good relationship with them. That's not always easy, but. So somebody said it just balances the chemical imbalance, correct? So I'm not totally sure what you're asking about. I think you're asking about medications, but and somebody can speak up and tell me if I'm hitting this wrong, but I will address this part. You know, everybody thinks that antidepressants, the SSRIs, selective serotonin reuptake inhibitors, we use them because we have too little serotonin. And that's not actually the case. There's a whole bunch of things that go on. The mechanism of action is also that it triggers certain second messenger systems that go and change RNA. And I mean, so you're changing proteins and everything. So it's not just you have more serotonin in your synapses. And the other thing is we don't really think of it as, if I'm talking to a parent, I wouldn't say all this, or a patient. I would probably just say it's gonna, this is what you need. Serotonin is gonna help you with your anxiety or your depression, but it's actually also about the tracts in the brain. And we know in schizophrenia, there's less pruning. So we all are growing tracts in our brain all through childhood and adolescence up until 25, 26. But we're also pruning those tracts all the time. And so one of the thoughts about schizophrenia is that there's not this pruning, and we see that with functional MRIs. And so if you have, one of the ways that pruning helps, or one of the things that we're able to do all the time is block out messages that are unnecessary. And people with schizophrenia can't always do that. So they hear things that, or have something in their head that they're thinking of they can't really identify that that's not a stimulus that needs to be ignored. Sometimes I'll, hear something in my house, but I have the ability to push that aside and understand doors are locked, all that kind of stuff. So it's about the tracts in the brain. It's about areas in the brain. Addiction really is kind of the addiction center. Some people call it is the limbic system. So the prefrontal cortex is what helps us all inhibit our impulses. So it's about more about that than it is about chemical imbalance. What steps did you have to take to start a private practice? Would you recommend doing private practice? Well, I loved private practice, so yes, I would recommend it. And the steps that I had to take was getting an office. I hired a nurse, I hired a therapist, because it's very hard to work on your own, because a lot of what mental health patients deal with is not just medical. It's also getting them resources, helping them understand how to manage the relationships in their life. So I had a team, and then I really wanted to think about what is a healing type of atmosphere. And so when I hired an architect, we really looked at nature and colors that are calming and artwork that's calming, even though I like really abstract art. It's just my preference. I didn't have any abstract art in my office. And then you have to get your own malpractice. You have to hire a good CPA. I hired a CPA that I would meet with throughout the year, because it's a business. And so you have to file everybody's taxes, and there's just a lot that goes into it. So you have to get a good CPA, one that understands private practice or small business. You have to, if you're going to take insurance, you have to get credentialed. And so that's just with insurance companies, that's just a ton of paperwork that you have to send in, and then that's done. You have to have a billing service or use software. Since I sold software, that's what I used. I didn't use that kind of software, but I did use software for billing. And you have to make relationships with people in the community. So a lot of my referrals were from word of mouth. So I knew neurologists, and I knew primary care physicians and other psychiatrists. And that was an important part of setting it up and being so busy. So like I said, I always had a huge waiting list, and that's not because I'm such a great psychiatrist. It's just because I set up a business while I had someone who managed my website and did can't remember what it's called, but makes it so that your name comes up on the top of the website. And, so there were a lot of things like that I did to make it successful. And then just having good people work with me. There seems to be conflicting opinions on learning disabilities among physicians. What is your take on ADHD and cognitive learning disorders? I wonder if the person's asking that some people don't believe that ADHD is real or that it's not real for adults. I'm not sure if that's what you're asking. Yes, okay. So, so I believe that there's ADHD in adults. We have it now in the DSM. That's our diagnostic manual. We call it the DSM. And it used to be that you couldn't be diagnosed with ADHD if you didn't have it in childhood, but we now recognize that there are some people that don't develop it until they're in their teens or later. And it's a developmental disorder, so that makes sense that it can change as you're going along, and as your cognitive needs are greater as you get older in school, they're much greater, then that stuff may show up. For women or for girls, you don't usually see the hyperactivity, so they get underdiagnosed. They just, get bored, or they struggle in school, they're quiet and they don't do well. And that's what we see with girls. And so we underdiagnose girls with ADHD. I absolutely believe in ADHD. I mean, there's just so much literature that supports that. When people don't believe that, I don't really understand why, or if they've, really looked into it. And then learning disabilities, like let's say dyslexia, we don't really know why that happens, but it is definitely a disorder, and it impacts people hugely. And they get disengaged from school. They feel like they're stupid. People with dyslexia and ADHD have higher rates of divorces, incarceration, drug and alcohol use. And people are afraid to give stimulants, which is like Ritalin and amphetamines, to people with ADHD because they're afraid they're going to develop a substance use disorder. There's absolutely no evidence of that. In fact, it's the opposite. If anything, it prevents that, because people with ADHD just have a much higher risk of having a substance use disorder. They're more impulsive. And when you're not doing well in school, you tend to hang around kids who are also not doing well and get into trouble. And so it's a huge deal. And if your school isn't addressing your mental health needs, your kids' mental health needs, there are laws regarding that. So there's Minnesota statute that schools do have to support kids. My father's a psychiatrist in India and believes that schizophrenia is just the result of untreated mental disorders that became too severe. Any thoughts on that? Well, I hadn't heard of that. It's not a hypothesis that I've looked into, but it seems that it's different. I mean, not everybody with really treatment-resistant depression or bipolar disorder becomes schizophrenic. So, but they usually are some of our sickest patients. Where do I find the link to the quiz? Don't know about that. Were there extracurriculars that you were involved in as an undergrad student that helped your chances? I think being older actually helped my chances because I came with some experience. But I did do, like I said, I worked in an ER and I worked as a medical assistant. But I think that being overall well-rounded is really important. More than just having all science. Do what you love and you'll get to where you want to be. When did you decide to start your private practice? Before I actually graduated. when do you think now is the right time? Also, how did you? Okay, so that's the second one. How did I balance my family life and my professional career? That is one of the reasons I set up a private practice, because my son was young at the time, and I needed flexibility. So that's how I managed it. And not everybody can do it that way. You have to take a risk. Starting a private practice is very risky for a lot of people, but it's hard to stop. It's hard to stop thinking about things because they're just, I don't know, they just seem really intense in your head. If somebody came in and was talking about feeling homicidal, that's really hard for me to block out. So I think trying to have some kind of distance, and somebody explained it to me once that you have to be callous. And it's not that you're callous, like you don't care, it's that you have a callus. It's something that's built up over time that allows you to protect yourself from all of those stories, all of those decisions. And so that's not an easy thing. Walk us through the steps of matching to residency. So when I did it, you had to, you took your step 1 of your boards, and I think you might have had to take step 2 also. I think you took step 1 just to get into your clinicals in your 3rd year medical school, and then you had to take step 2 before your residency. But I could be wrong about that. And so you decide where you want to go, and then send in your application. I mean, it's just the same as medical school. Send in your applications, then you go and you interview at a bunch of schools. And everybody told me that you should go and travel, like you should go somewhere that you wouldn't necessarily think about living in, because this is like your last chance. And I didn't do that, but that was a great idea. I thought I should have done that. How do you cope when issues that a patient's facing is outside of your control? Home life, homelessness, oppression. It's out of my control that they have oppression. It's in my control to try to help them figure out a way to get out of that. And same with home life or homelessness. I can't put somebody into a home, but I can work with them long enough to try to make them stable enough so that they can keep a home. It's not a great answer. It's a hard thing. So what I do is I also have a team. So that's why I had a nurse and a therapist, because I couldn't handle all that stuff on my own. How has psychiatry changed with the pandemic? We expected there to be a mental health COVID crisis. We thought it was going to be like 3 weeks after COVID hit. It didn't. It's like a year later now. We are just, people are, breaking down, and just, they haven't had treatment, and they haven't had enough treatment. And so they're in our emergency rooms. It's really tough right now. And we are seeing more patients. We did go to virtual. So a lot of us see patients virtually for safety, for their safety and for ours. But we're now trying to kind of right size that. We want to keep some of it virtual because it's actually very easy for patients. They don't have to take so much time off of work. And you get to kind of see their surroundings. You see if they're hoarders or whatever the case might be. And so there's been some benefits that way too. Yeah. Oh, and then we had this whole plan of rationing care. We had to start rationing how many ECT cases we did, because we needed to keep the ORs free. And we had to, our plan was that we would start, if we had a ton of patients come in, we would start seeing them every other day rather than every day, which is not ideal. But in a pandemic, in an an emergency situation, it's sometimes what you have to do. None of us are taught to ration care, but that's what we had planned. We didn't actually have to do it, but we might now. We're actually kind of looking at that right now, so. I don't think that there are any other questions, and I think we're probably bumping up against your time. Anybody have any questions that they want to speak up?
I remember you said that you had things planned to talk to us about. Is there anything you want to go over before we end?
Say that again.
Like at the beginning of this meeting, you said that you had your own plans for what you wanted to talk about, but because you got so many questions, you wanted to focus on that. Is there anything that you plan on talking about that you haven't said yet?
No, I don't remember saying that. I very possibly could have said that, but I don't know what. I didn't have a big plan of what I wanted to say. I kind of want to just answer your questions and give you a little bit of an outline.
Okay, thank you.
Thank you. Do you still have time? Do you want me to answer the other questions that are coming in?
Yeah, that's fine.
So what are psychiatry PA's involvement? PAs can work independently in every type of practice other than psychiatry and maybe one other. They need to have supervision on patients with, we call it emotional behavioral disorders. That's kids with severe illness, or SPI, which is severe and persistent mental illness, or SMI, we call it now. So PAs need to have supervision for that. Otherwise, they can work independently. And nurse practitioners can also work independently. Do psychiatrists focus more on prescriptions or more on therapy? It's, you know, a lot of people focus on therapy when they're first getting out of school because we've done it, we've been trained, we're used to doing it. But once you get out there and you haven't done it for a long time, I kind of felt like I started to feel like my people that are actually therapists are doing that a lot better than I am. And there is such a lack of psychiatrists, and especially in Minnesota, we were in the bottom 3 for child psychiatrists in the whole nation, which is just sad. So I really believe that psychiatrists now have to focus on medication if you want to look at it from an overall public health strategy. But people are free to do what they want to do. And I have friends who only do therapy. They hardly ever do meds anymore. So.
I think that was the last of
I have one more question, actually. So I was wondering how shadowing psychiatrists would work. Is that a thing, or is it like not work because the patient's, you know, the confidentiality and everything?
No, it does work. You have to sign, take a course. It's a small, like an LMS learning module, and you have to get it okayed through the residency program if you are doing it at the U. If you were doing it out in private practice, I would just call, like my son wanted to talk to a neurologist, so I just called a neurologist who's a friend of mine in outpatient practice, and he just came over and he spent a day with him in clinic and he saw patients with them. And you can do that in psychiatry. I mean, especially if you're in a learning hospital or learning system, and he's at Naran Clinic and they have learners there, so people are used to it. Okay, in my practice, that would have been hard for me when I was in private practice because I had no learners. Nobody expected that, but I would have had to call each patient and say, are you okay with this? I'm planning on having somebody that day. Can we reschedule if not?
Okay, yes, yeah, so I guess that was my main question. Like the patient would say whether or not they want someone else there shadowing you, right? Okay, thank you.
Oops, sorry, I didn't unmute. Always, they have to agree.
I think that was all of it. Thank you so much for coming. It was really interesting to learn for the first time about psychiatry. So thank you so much.
Yeah, you're welcome. Thanks for having me. I hope to see you guys again. Please feel free to contact me. I'll put my chat's disabled, but I'm Holt0402@umn.edu if you want to get in touch with me. Thank you.
Thank you.
All right, bye.